All right. So APTU is the first thing you will see. Now you don't have all your acronyms, and I don't know if you have something to write with, but it's a few acronyms you're gonna see throughout this document right here. We're gonna talk about a couple of them. APTU, the first one you see, stands for their level of consciousness. So the A is obviously are they alert, and if they are alert, are they oriented to where they are? You might ask some question if they can speak, like, hey, who's the president? Whatever, trying to see their mental state. The next is responsive to verbal stimuli, meaning exactly that. Can you talk to me? Can you tell me something? Then responsive to painful stimuli. Out here, we're just gonna use is known as a trap pinch. You just grab the trap and you pinch it. And if they can move, they're responsive to verbal stimuli. So they're still there. And then the last being unresponsive. Not unconscious, because they could be unconscious, but unresponsive at all. You try to talk to them, whatever, pinch them, nothing. They're unresponsive at that point. That's your APTU scale. Their level of alertness. All right. Then we have Apple, which stands for their allergies. If they have any, usually you'll find it from a dog tag or a person that can speak that would tell you. Medication, their past medical history, if they have any heart problems or something like that, their last oral intake or the last thing that they ate, because you're going to need that for the TC3 card, which is on the back. All them type of questions need to be answered on that TC3 card or the 1380. This is a blown up version. That's a little smaller than that, but I wanted you to be able to physically be able to see all the little sections that need to be filled out. And you gather that through your assessment, either asking them or looking at their dog tags or whatever you can find. All right. Then we have burps, which stands for the blood pressure, respiration, pulse, pearl, and pearl is another one. Pearl stands for, are the pupils equal, round, and reacting to the light as they should? So in order to assess this, we're going to use what's called a pin light. And we're going to look inside their eyes. You probably see it on TV when they like follow this pin or whatever. And we want to make sure that your pupils are doing what they're supposed to do. Because if you have some type of brain or neck injury, they might be super dilated or they might not move. One might move and the other one going the other way. You're looking for those type of injuries. Then we have CCT, which deals with their condition if they're going into shock. Because y'all know some of the signs of shock, right? Having cool, clammy skin, maybe your pulse rate is going crazy. You check it for that. That's CCT, color, condition, and temperature. And the only way you can really check for that is to pull your BSI back, which we're going to talk about in a minute, and feel on their forehead or whatever and look at them. See, are they bluish around the lips? Do their skin look like an off color than a normal person? Are they showing some signs of distress? All that's in CCT. Then you have CSF, which stands for cerebral spinal fluid. So if you're losing any of this and it's outside of your spine, there's probably a problem there. And we got a number of areas that we can locate that CSF. Then you have decap BTLS, everybody's favorites, because every area on the body you need to check for decap BTLS, which stands for deformities, contusions, abrasions, punctures, burns, tenderness, laceration, or swelling. And you check the entire body for this. And I'll show you how to do that during the assessment, but you should know decap BTLS because that just shortens it for you when you have to actually call it out. Nobody wants to sit there, deformities, contusions, abrasions, every piece of the body. You can just say decap BTLS. All right. We have DEC, which deals with your equipment. Is any of your equipment expired? Is it raggedy? Is there any floaties inside your IV solution? Is it discolored? That's what DEC deals with. It stands for defects, expiration dates, or contaminants. That's dealing with all your equipment. Now, all your equipment has expiration dates or something that you need to look at to make sure that it's working properly. Then you have JVD, which stands for jugular vein distension. This also is dealing with head and neck trauma. The veins in the neck will be just abnormally large and stretched out from excessive blood pumping. Then you have TD, which stands for tracheal deviation, meaning that this little area of your throat may be to the side, one way or another. That also says that you have a head or neck or spine injury. We talked about Pearl. Now BSI, that stands for what? I know some of you already heard that before. BSI. Anybody know? This is your BSI. Where's my little thing here? My little... This is our BSI. It stands for body substance isolation. You always, if you operating as a medic or whatever, you always gonna have a pair of gloves somewhere on you. Because if they do have something, you don't really want to get it. Even though it seems kind of silly, you're like, man, we're in a combat scenario. Why in the world would I stop to put some gloves on? Because you still want to be safe as you can. You know what I'm saying? So this BSI, body substance isolation. BSI for my buddy and I. BSI for my buddy and I. Everybody know that. So let's repeat it. BSI for who? For my buddy and I. That's to keep us all protected. All right, then you might hear PMS, which stands for post motor sensory. This is every time I go through this scenario and I show you, I want to cover this first, just in case I start going really fast, you will know what I'm talking about when I start doing it, because I'm going to show you a live demonstration. And I'm going to be like, decap, DTLS, and you're going to be like, what? That's why I want to go through the acronyms first. All right, so PMS, that's my post motor sensory, meaning that I check a post where a post can be checked. I might ask you, can you wiggle? That means your motor is good. Can you feel this? Which finger am I pinching? Oh, my ring finger. There you go, your sensation is good. That's my PMS, all right? Then we have tick, which stands for tenderness, instability, and crepidus. This is mostly dealing with the bone. This is mostly dealing with the bones. When you check a tick, you may hear some grinding or something like that, because every injury is not seen by the eye. Some of them are under the skin. So in order to check that, we listening and feeling for irregulations in the bone when we rocking it. So we hear grinding or something like that, that's obviously not normal. So that's our tenderness, instability, and crepidus, our tick. All right, TRD, tenderness, rigidity, and distension. That's dealing with your abdomen. Everybody know we got miles of guts in here, right? So we feel in this area gently to see if we feel hardened mass in some areas, like a Charlie horse. Anybody ever got a Charlie horse in the stomach? Man, that's painful, ain't it? So if you feel something that's like that, that's abnormal. If you feel the belly swollen to a unnormal position, that's your guts in the distension mode. They're swollen for some reason. So we're gonna check the 4 quadrants to make sure everything is where it's supposed to be. Remember, this is a patient assessment. We need to know as thoroughly as possible what our injuries is on this patient. And it all will be documented on the 1380, everything. So if you look at the 1380, it has a picture of a person or a silhouette of a person. It has the front of the person, it has the back of the person. Every time you find an injury, it should be documented by putting an X there and then a small initial. If you look right above that, it gives you some examples. Like it says, this person was hurt by GSW, which is a gunshot wound, a grenade, they fell, they were burned, blunt, artillery shell. It got all these things that need to be checked to say what it is that happened to this person and what location it's in. So when you pass them to the next hire, they already know what's wrong with this person. They can fix them faster, right? It also got a whole bunch of other stuff on there. Oh, come on. Yeah, I suck with this. Go lock now. Appreciate it. All right. Just put it.
I can't see it.
You can put it down and then. There you go. Yeah, hold like it. It's too short, like the song. But either way, those are some of our acronyms that you're gonna hear me cover in this patient assessment. Okay. All right. So go ahead and turn back to the front page of the patient assessment, and I need a volunteer, just one. Now we are medical professionals here. Come on, you in the front. I need this little space right here, please. You'll slide over here or something. And I'm gonna do a real live patient assessment. Now it's a whole bunch of steps in there, but the thing is, I'm gonna go through them as slowly as I possibly can, hitting them in order. So this right here, the patient assessment here is recognized. That's good, that's good. It's fine. For if you plan on going for the expert field medical badge. you plan on going for the expert field medical badge, you need to really learn this because this is what kicked majority of the people out of the course. TC3, TCL1, or CTL1 is just the hardest portion of the entire badge obstacle. All right, so we're gonna start with the beginning. I think you start at AFPU, right? Yeah. So we already determined what that is. I'm gonna go ahead and throw this tourniquet on his leg because we're gonna say he got a GSW right there in his right leg. You already learned how to do this out at the FTX, so we got not gonna cover that, even though that's a separate task. You didn't learn it?
He said don't do that.
He said don't do that. It takes more time.
And he said it decided under.
Well, I mean, you learn how to put a tourniquet on, though, right?
Yes,
all right, so that's why I'm trying to get to that one. So I ain't gonna go over that because that's a whole task in itself for the badge. So I'm gonna go ahead and start it from where you already learned, which is putting it high and tight. I'm not gonna kill you.
All right, so
Putting the tail all the way around. Pulling back my Velcro strip. Turning my windlass rod until it don't turn or the bright red bleeding stops. And I'm gonna secure it and put the tape over it. Now I cannot forget to put T time and date because that's gonna determine if this person can keep his limb or not. Depending on how long I have this tourniquet on this person. So I'm gonna go ahead and stick a little piece of medical tape. It's real easy, man. They gonna turn no hair off. Okay. I got my little marker here, which you're not gonna have. You're just gonna pretend. And I'm gonna put my T, which is my cross or a tourniquet. And then I'm gonna put the time, which right now, 13:48. 13:48. And my date, which is 29 July of 21. Can't forget that. That's a part of the task. And I'm going to start from there. We already took care of that. That's taken care of in a portion of assessment known as care under fire. So when you first rush in, you don't go in probably like you learned out there at the FTX, like, hey, y'all, let me get you and carry you over here. Cover the rear, cover the front. Usually it's bullets flying somewhere. That's how that person went down. So you do whatever you need to do, high crawl, low crawl, and all that stuff to get to your person. It's called care under fire, meaning that you only taking care of the immediate life-threatening injuries. You ain't assessing nothing else. Whatever they say or whatever you can see, that's what you're gonna take care of, and you're gonna pull them out of what they say is the X. Pull them off the X, put them in a safer zone. It's a safer zone, meaning it's not safe. It's still bullets flying, but you behind a tree or a bush somewhere, and now you can perform your entire assessment. So we're gonna start from there. The tourniquet is already there. When I walk up, in my carryover, this person went unresponsive. So that means he's not talking to me. Hey, how you doing? Nothing. So I check for my A in the AFPU scale. What's my next letter? Hey man, do you hear me? Hey, do you hear me?
yes, sir.
Does this look familiar? Does this look familiar? Hey buddy, you okay?
Yes, sir.
BLS, right? You learned that. It's kind of the same thing when it comes to this in the airway, breathing and circulation. So we got no response out of him. What's our next letter in the scale? The P. So we gotta see if he responds to painful because he ain't respond to anything else. Okay, so we gotta jump out of him. So we know he is there and he can move if I cause him a little discomfort. All right? And the other one is unresponsive. We can get past that because we know that he's responding to pain. That's one of the checks on your 1380. He is responsive to pain for stem line. All right? All right, so where are we next? We moved him out to X. We realized he responsive to painful stem line. Okay, so now that we already got his status as far as his alertness, we're gonna go assess his airway. All right, so we go A, B, C. Airway, breathing, circulation. Airway first. How do we do this? This look familiar. BLS. We look, listen, and feeling for airway. We're just trying to make sure he got a patent airway and he not, compromised in any way. He's not, or something like this. If he's breathing normally, okay, we can keep on going. We don't have to worry about dropping an MPA in him or nothing like that. We can continue to assess him. Now we in where? B. Breathing,
B.
right?
No, that's C. Assess breathing. Assess breathing. B. No, that's C. No, B.
Oh, no, she's saying A, B, C. So yeah, A is airway, B is breathing,
Airway.
C is circulation.
No, we don't do that, but we gotta get an airway first. All right. So where are we? Breathing? All right, so how are we checking for breathing? What does it say?
Even rise and fall of the chest.
Chest rise and fall, that's it? Somebody grab that book right there. What does it say in breathing? Which should be like midway down the page.
We have a beep.
You do.
Inspect the chest, open body armor. If
Okay.
present. Inspect for anything penetrating chest wounds, deformities,
All right.
contusions.
That's good. So I'm gonna go ahead and take off this person's body armor to this level. Open it. Look for decap BTLS. No, nothing there. Is he breathing normally? Yes, right? There's nothing wrong with him. He's breathing normally. Part of our assessment. All right, so he's breathing good. Now what? Circulation. We need to check his circulation. Here, we're going to do a blood sweep. Are you following along right there? I know. I got the extended version. Mhm. Yeah. So what does it say? Perform blood sweep. Any additional hemorrhaging? Our blood sweep is going to be as follows. Thorough. Look. 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 All the way down this person. Every way. Now once you get over here, if you can, you're going to cross under the body. And your fingers need to touch and pull them out to see if any blood is there. The same thing this way. If you cannot reach all the way around your person, you just will go underneath. I say people do it this way, they do it this way. Just remember to hit every part of the back of them and make sure you're looking for blood. What are you looking for? Blood.
After the field, you said only
Don't worry about that. We get you ready for EF and B. All right?
So it's
Expert
visual
field
when
medical.
you're like out there under fire.
Mhm.
You're looking out there like, okay, his leg's bleeding out, but now he's moved it casually.
Right. So we doing a thorough trauma assessment on him. So if we were still taking fire, we wouldn't even be doing this much. We just fix the stuff that's broken and get him out of there. But we got him out of there already. Now we're in our circulation. We're gonna start doing our full blood sweep, the entire body, not to miss anything. And while I'm going through, I'm just going to loosen his shoe and take it off.
Damn.
Whoa.
Don't be like that. It's a hot day outside. He ain't know that was going to happen today. Damn. Good thing I wear the one with the hole in it. So you will loosen the shoe and you will take the shoe off. There you go. Massage your feet right quick. Looking for blood. All right, after my blood sweep, what am I going to do? It's right there in the book.
So no. Check for images, control any bleeding if you found any.
We didn't find any.
That's what I mean. This is like kind of. Alright, so check the pulses.
Okay.
The skin color.
All right. So in the circulation, I need to check some pulses, right? All right. So before that, while I'm in circulation, I was over here on the leg. Does it say I can downgrade this tourniquet or attempt to? Right there in circulation. It should be a little admin note. Convert pressure dressing. So we want to convert that tourniquet down to a pressure dressing while I'm doing all these blood sweeps, because right here I know he has no pulse because I cut it all off. So I want to consider downgrading that to a pressure dressing so he may be able to save that limb. All right, so grab me, throw me that the green one. Thank you. So this is known as an Israeli dressing. They got a lot of different types of these, and they all got different country names. But this one in particular is an Israeli dressing with an alligator clamp. Now this is meant to be a pressure dressing. It should come in a pack like normal, but because we're gonna continue to use them, if you take it out the pack, it will have like pins. You want to shake the pins away from the patient so it don't fall on them, remembering not to touch the white part because it's sterile. The white part is sterile. I'm gonna put it directly over the wound. I'm gonna hold it down, and this bar is a pressure bar. Every time I wrap and loop around, it's putting pressure on the wound. So I'm downgrading this tourniquet, which is a permanent, to this pressure dressing, so he could potentially keep his limb.
Sorry, before putting that, don't we want to put gauze or something like that inside the wound?
Not in this one. So that's another one. That's packing using the dressing, but we'll do that one in a minute, okay? All right, so I'm downgrading this tourniquet. I put one loop through, and then I take it back the opposite way, trying to cover all white and cover this clamp if I can. So I really don't want the white to be exposed. And the more I go over this clamp, the more it's putting pressure on that wound. And that's what we want, to keep it from bleeding. And then once I get the clamp around, I just try to cinch it onto the last wrap with the alligator clamp. All right, so I got that there. Now that I have that there, I can loosen but never take it off. If I see this bandage start to fill with blood again, I need to tighten it back up. But I'm gonna slowly turn this windlass rod. If the bleeding doesn't return, I go ahead and secure it back in a loose fashion, but never take it off, just in case I need to cinch it back up again because this ain't working. All right, so now that I've downgraded that to a pressure dressing, I'm gonna continue up my arm. Over here, I find bleeding in this upper axillary area, probably about right here. I find bleeding. It could be from anything. It doesn't have to be from a gunshot wound. This is when I'm gonna apply another dressing. Can I get the compact gloves, please? And that wrap. All right, so this is the part that you were talking about earlier. This is dressing the wound with the bandage dressing. So what I do with this is we pretend that this is closed, open it. I take it, making sure I don't let it hit the ground. I'm gonna hold it in my dominant hand, and I'm gonna unfold it while I'm packing it inside the wound, directly into the wound, and I wanna put this entire roll into the wound, all of it. So if I gotta sit there for a while, pack, grab, pack, grab, pack, grab. Keeping pressure on the wound, but packing this wound up with this combat or quick clot gauze. There's different kinds, depending on what unit you're in. This is supposed to help to relieve the blood from coming out and make the blood clot quicker. So I'm gonna go all the way with all of this wrap, and it takes a while. Pull, pack, holding pressure the entire time. It's not hurting me. Patient assessment is a beast. It's a lot of things to do in it. But this is two other tasks that I added in there too, with this dressing and downgrading the pressure dressing. All right. So now that I secured the entire row, now I can wrap that row. You can use an ace bandage, whatever the case may be, to wrap the row, to keep it in place. And remember, I'm still in circulation. Wrap it tight. Cover all of the quick clock gauze. Alright. There. Some of them come with clamps, then you just secure it with the clamps. And we got that taken care of. Alright. Where are we now? We need to check some pulses, right? All right. So how does it start me off in the pulse check?
Check the radius pulse, which presents the blood pressure is at least 800
Mercury's in the blood. We got it.
or 80. Sorry about that.
80 millimeter.
800 mercury.
Okay. So I have a pulse, but at this time I'm gonna check bilateral pulse because I'm gonna have to do that anyway. So I'm gonna bring one to the other, and I'm gonna check bilateral pulses. What else does it say? My pulse is present. I'm checking to make sure if I hear like weak and thready or something, this person might be going into shock.
It just says the blood pressure needs to at least be at 60 millimeters of mercury.
Okay. So we have that pulse. Now what?
Then we have to assess the skin colors, condition, and temperature.
Pull back my BSI. Unless I hear cool and clammy, which again would tell me he's going into shock, and I need to initiate saline fluids or something for him, meaning I need to give him an IV. But in this instance, I feel nothing there. Okay, he doesn't have that one.
And then perform a detailed physical exam. So meaning starting with assessing the head.
All right. So now that we got through all this, we checked some pulses and everything. Now it's time for our final, our detailed exam, meaning from head to toe, all the way around, using our PMS, DCAP, BTLS, TIC, and all them acronyms that I went over with you. This is where it's gonna come into play. So the first thing, I need to look at him. I'm gonna feel up his head with my fingers, checking to see if there's any indentations, meaning the bone is cracked or fractured or broken. And I'm gonna go around the back of his head doing the same thing. If he has a Kevlar on, I need to take it off because I need to feel this entire thing. I'm gonna walk around the back of his head, feeling for the same thing, and around his jawline. Nope, nothing's going on with that. I'm gonna use a pen light, which we don't have none, so I'm gonna pretend. Because I need to check his eyes, right? Okay, so now I need to check his eyes. What I'm looking for in his eyes, I'm gonna open his eyes and I'm gonna see if he can follow these, his pupils. Looking for pearl, that they're equal, round, and reactive to light. Because the pen light has a light on it. I'm looking for raccoon eyes, meaning look like he didn't sleep in about a week. Raccoon eyes, that would tell me that he got some injury going on. I look at his ears, looking for CSF. Somebody tell me what that stands for. Cerebral spinal fluid. Should it be coming out of his ears? Okay, because that indicates what? There's a leak for sure. So that means that he got some type of head trauma or neck problem or something that's causing his CSF or either blood to be in his ears. I'm looking at the back of his ears looking for battle signs, which is a darkening that comes down the ears. All right, I see none there. Where am I now? Look for broken teeth and inspect his nose, right?
Check for airway obstructions as well.
Okay, so now that I checked his eyes, I checked his ears, now I'm gonna look at his nose, make sure it's not broken. I'm gonna look up his nose, looking for CSF or blood. I'm gonna open his mouth, looking for broken teeth or something that might be back there, maybe he swallowed his tongue or something that tells me something else is wrong with him. After I inspect that, that's his entire head that I inspected. Now I need to go to the neck. Okay, Somebody tell me what decap BTLS stand for. D, deformities. C, contusions. A, abrasions. What is an abrasion? All right. Decap, what is the P? Punctures, man, there's a hole in them. B, burns. T, tenderness. He will tell me if it's tender because he'll move. He's responsive to pain. L, lacerations, meaning a minor cut. What is the S? Swelling. So that's all that I'm looking for the entire time I'm inspecting him. Now I'm on his neck. So I'm gonna look at his neck, the back of his neck. I'm gonna feel for step-offs, is what they call it. That means his spinal cord or his C-spine is out of alignment. You have natural notches in your spine. Now, if it's like this, you feel one in, one out, one in, and they like all jagged, he probably fell on his neck. He probably got a spinal issue. So we checking for that. It's called step-offs. We're gonna feel for his C-spine and make sure that everything is in alignment. Once we get done with that, we're gonna feel for decap BTLS in his neck, looking for anything, and then we're gonna check his trachea and make sure that it's not deviated off to this side or off to this side. Everything should be in alignment. Then we're gonna check for jugular vein distension, meaning his veins is abnormally sticking out in his neck. Nothing there. Now where are we? In the chest, right?
You did tracheal deviation and checking the cervical collar already too, right?
Yep, for step-offs.
So for assessing the chest, you gotta inspect the decap BTLS as well.
All right, so we already got him exposed from our earlier checks. His chest should be open and showing. Now I'm gonna check here, his clavicle, make sure that there's no tick or decap BTLS. Then I'm gonna do prayer hands down the inside of his sternum to make sure that nothing is, again, rocking or breaking or something, or I hear cracking sounds. Then I'm gonna squeeze his girdle. All right, I hear nothing. Looking for decap BTLS, feeling for tick. What else I need to do in there? Auscultate, right?
Yep, auscultate these four.
Can I get that right there? So I'm thoroughly inspecting his chest now. Auscultate, 4 fields, because there's 4 lung lobes. Either way. All right, it might not be over there. So that's the thing you see when the doctors have it around their neck, like this, and they put it in their ears, and they tell you, breathe deep. Y'all remember that? Everybody had that before, right? So that's exactly what we're talking about. I put the things in my ears, and I check his 4 lobes. Everything is good. Now what?
Palpate the anterior area of the chest, screening for tick.
Yep.
Observe for progressive respiratory distress.
I'm looking at him, making sure that his chest equally rise and fall. Not one lifting up and one not, or they alternating or something like that, because that would tell me he probably got a chest wound. All right, so everything is good there. I'm moving to the stomach, right? All right, what am I looking for in the stomach? Decap BTLS. Inspecting for decap BTLS. I'm gonna do this wave over the 4 quadrants of his stomach, feeling for pulsating masses or distensions of his intestines. I feel nothing there. Everything is good. Now where? Pelvis. All right. So I look for decap BTLS. I feel for it by grabbing right around his waist, push down, and put the book on the shelf. If it's some type of break there, it's definitely he gonna definitely move at some point, because I'm gonna feel it and I'm gonna hear it like this. So he just push down and in. Everything is good there. All right, backhand swipe Everything good. Looking for a prior prism or anything like that, because that would entail that he probably got a lower spinal injury.
Access lower extremities.
Okay, so now I'm going all the way down to the bottom of his legs before I come back to the top of his legs. And if I happen to move this person, I need to re-inspect my interventions. Everything that I fixed on him, I need to make sure they still working. So I'm gonna go down here. Alternating, I'm gonna look for decap BTLS, feel for tick. My hands are alternated, I push down and in. Feeling for or something like that that's not normal. Push down, in, alternating all the way down. And when I get to any area where a post is, I check for a post. If I feel a post is good. Can you wiggle? Can you feel? Push down. Pull up. Everything good there. His circulation is great. He has a pulse. He can do everything there. Now I'm going to go to the other limb. Excuse me. I don't want to step over the patient because I don't want to fall on him. All right. So I'm going to do the same thing here. Is my intervention still holding? Yes, they holding great. I'm going to check the rest of his leg for the same thing. Feel for a pulse. Can you wiggle? Can you feel? What toe am I touching?
Big toe.
Push down. Pull up. All right, so we good to go there. My intervention is still holding. Checked it already. Now I go to my upper extremities, right? All right. My upper extremities, I'm looking for the same thing. I know it's a wound here, so I'm not going to try to grab the wound. I know it's something wrong, but I'm going to alternate around it. And then when I get to the bottom, I'm going to check a pulse. Can you squeeze my finger? Which finger am I touching? Middle finger? So we good to go. Circulation is working there. My last upper extremity. If I had an IV here, that's the same as an intervention, and I need to check it if I move him. Check it from the top, going down. Nothing. Pulse. Squeeze my finger. What finger am I touching? All right. He's like, pinky. He has a reporter face. All right. So I inspected the entire front of my patient and his head. What's left? The back of him, right? All right. So I have an IV. If I had an IV, it usually probably would be in this arm. I'll be extra careful with that. But I'm going to roll him onto the injured side. I'm going to pull him close as I can without touching that wound. I'm going to grab, put my legs underneath his, and I'm going to pull him up onto me so that I can check his spine all the way down, looking for decap BTLS, feeling for tick, and step off, making sure his spine is in a line like it's supposed to be. And then last but not least, I need to check his rectum to make sure there's no CSF or blood. And the way I can do that is called a credit card sweep. Sweep right down the crack.
Oh my
God.
Oh no!
And look for any CSF or blood that might be coming from his rectum. After I'm done with that, if I was ready to transport, I would drop him onto a litter. So I'll pull a litter close, put it close enough, I will grab him and I will put him down onto the litter. That way that would help me in my transport. So now that I moved him, I need to check my interventions again. My IV line's still holding. This is called a focus assessment. You focus only on the injury. Is my intervention here still holding? Yes. Is my intervention here still holding? Yes. Everything is good. Now what? Package them and get them ready, right? So I need to finish doing my card. Give me one of your cards. At this point, as you can see, my patient came back to responsiveness and he's talking normal. So this is my chance to fill out all the things that I was missing. Meaning, all of these things. Hey, are you allergic to anything? Are you allergic to anything?
Yes, sir.
What are you allergic to? Nothing? Okay. All right. What's the last thing you ate? What did you eat? You ate an MRE 3 hours ago? All right. Do you have anything in your medical history that I need to know about? Any heart failure or something like that? No? Everything good? Extra tough? Well, we can live with that. Everybody should have an extra. So either way, we went through those things. And what's our last thing on that list? So we get allergies, medication. Are you taking any medication? Or last oral intake, events leading up. What were you doing before you got shot? Okay, you were on patrol? Got it. All right, I got all my things marked. You got a gunshot wound here, gunshot wound there. Nothing was on the posterior or the back. My tourniquet was applied to my right leg at this time because it's right there. Everything needs to be filled out inside this card at this point. Did I give him any medication? No, I didn't. Was his tracheal intact? Yes, it was intact. He was breathing on his own. No chest tube or nothing that I gave him. All right, what is his order or category or his evac category? Now I need to find that out. Okay, so he has a gunshot. He's in stable condition right now. Nothing is going on, so he may be routine, right? Is he urgent or is he surgical? What would he be? He got a gunshot. I didn't fix the gunshot. I just stopped it from bleeding. What do you think it is?
I'd say routine because he's talking and he's responsive and everything's under control.
All right, so you're going to say routine and the next medic going to say that his is urgent. Who you think they're going to come get first? Because he still got a bullet in there. It can go down. It can go soft quick. We haven't removed it.
Okay, good news. Urgent.
All right, so we got an urgent. So then when we call up the 9-line, we got all the information that we need to call our 9-line. All right, did I give him fluids? No, I didn't give him fluids. Or if you did give him fluids, or if you gave him medicine, you go ahead and put that you gave him medicine. And then at the end, as a first responder, you put your last name, first name, and your last four. This usually gets pinned to the uniform, because it's a smaller card, pinned to the uniform, and then this goes with him in transport. You will always remember until your emergency evacuation comes to pick up this patient, you have to always reassess the I-5. The I-5 is the initial assessment, your focus assessment. So what is the initial assessment?
Check for responsiveness.
Okay, make sure that he's still responsive and all that type of stuff. What is the focus assessment? We just talked about it like 2 seconds. What is the focus assessment? What does it sound like?
Talking about
No, it's more less general. So that means my focus assessment is only the areas I know is affected. I'm gonna make sure this still working, make sure that's still working, make sure this still working. That's your focus assessment. Any interventions that you did, making sure they're still holding and he is not degrading. All right, I'm gonna reassess my evacuation category. Meaning, is he urgent? Is he urgent surgical? Is he going into an altered mental state trying to get up and fight me? Is he trying to shoot me? You know what I'm saying? Like, we need to keep that updated and make sure we keep an eye on him because things go down quick.
he's trying to fight you.
Could be. So, you got to make sure you reevaluate. That's the I-5s and continue to get the vitals. The vitals is his pupils, his CCT, his respiratory, and his pulse rate. That's his vital. At that point, you just holding down the fort and waiting for your evac to come. Or if they tell you to move him to a specific area so evac can come, that's what you do at that point. Everybody good? There's a lot of little stuff, right? Now guess what?
We gotta go home.
You gonna do it.
Oh,
All right, my friends. We got some stuff here, but probably not enough for everybody to have their own. That's why I need y'all to group up in a group of 3. Because it's what, 16 of y'all, right? So make it a group of 4. Okay. Okay.